I'm going to be talking about the context in which the HMI provisional report has come out and the recommendations need to be implemented, and more broadly the health policy and the health systems context, because I think all of this is coming at an interesting time. It's coming at a time where health policy is changing and our expectations of the health system are changing. There's a real desire to diminish the hard lines between the public and the private sectors. And so it's important when we're looking at the HMI to think about the context in which it's been operating, the context in which the report has come out, and what that context could mean for implementation of the recommendations and for the health system as a whole. And of course, that context is national health insurance. This much talked about, little understood by, frankly, everyone, I would suggest, concept, this idea of moving towards universal health coverage. There is a recognition of an impatience with the separation of the public and the private sector, and a discomfort with those inequities. When we're supposed to have a single health system, we're supposed to have a minister of health, not a minister of public health. And so what's important, I think, is that the HMI, as Marcus said earlier, has now provided the evidence that we would need to make the changes that are required within the private health system. Because previously there was a lot of rhetoric and not a lot of information. And the panel has worked for years now to get that information and to justify the recommendations that it's made. Now I'll refer a bit later to one of my concerns, which is that that kind of thinking hasn't been done for the public sector, or well, it's been done, but it's just not really finding its way into policy. And I think we're going to have a bit of a disjuncture there. But it is important that this evidence has now been found, and that there are real concrete proposals for how to move it forward. So what does NHI see as the future of the health system? And this is going to be a real summary. But firstly, it's meant to be our answer to universal health coverage. And universal health coverage means everyone, universal, access to services that are of an acceptable quality at a price people can afford, or that is not determined by ability to pay, but rather by need. Now, universal health coverage doesn't necessarily equal NHI. NHI is the way that the ministry has decided to try and pursue universal health coverage. And I think it can be convenient when there is pushback against some of the problems in NHI to say, well, if you don't believe in NHI, it's because you hate poor people. And I think that's a really unfortunate approach that is often peddled, because what it means is it shuts down debate on some of the real problems with NHI policy and the real desire amongst many people who do in fact want universal health coverage to ensure that we're going about it in the right way and in a way that's going to achieve the change that we want. What NHI envisages is a separation of providers from purchasers. So rather than having budgets going to provincial departments who then provide the services as well, you will have a fund purchasing services from providers. Now, interestingly, that's what happens in the private sector, right? We have schemes and we have providers. And yet there's this assumption that by making that separation, it's automatically going to create more equity and more purchaser power. And I think we've got to be careful around those assumptions and ensure that when we're developing policy, we're actually creating policy that will actually result in the outcomes that we're looking for. The bill doesn't talk very much about the private sector at all, and I'll talk about that in a bit. It's interesting, but the bill doesn't really talk about a whole lot, to be honest, other than the NHI fund, so I don't know how much we can read into it. But there's very little detail in the bill. There's been a very long policy making process. There have been 2 iterations there's been the green paper and the white paper. There have been thousands of comments, and yet there's very little detail in the guts of the bill. So much is left to these committees that were advertised for in July last year. Everybody flurried to make nominations. We carefully got an extension on the nominations process. We made all these nominations. We don't know what the outcome is. And those committees are supposed to decide what's going to be in the basic package. Interestingly, a similar idea to what's come out of the HMI, that there should be one basic package that is available to everybody. It may or may not be the same basic package that we're envisaging, but that's the idea. on how much how much providers are going to be paid, on how the payment mechanisms will work, on how information will be collected. All of these issues are left to committees that we don't yet know about. And I think one of the main problems in the NHI bill is that there's no real acknowledgement of the context in which it's being made. And we're not talking context, but in this bill, we're acting like we don't have a very, very, very weak public health system and a private system that needs the implementation of all of these recommendations in order to make it function in the way we need it to function. You've probably heard about this, but the OHSC's assessment of health facilities last year found that 5 of the 696 facilities assessed meet the 80% requirement for certification, and that would be you would have to have a certificate from the OHSC to be accredited by the NHI fund, which is a separate process, in order to be paid by the NHI fund. And the theory is the NHI fund is the only payer, and so we've got 5 of 696 facilities that meet the minimum standard set by the OHSC. So we're not sitting in a great place to start with a new financing system. That obviously shows how much we've got to do, and not that we must stop. But we need to also recognize where we are when we're creating policy and trying to make change. It also doesn't recognize things like we've got an effective post-freezing in Gauteng at the moment and in other provinces. It's almost impossible to hire healthcare workers, and NHI policy assumes that we will have healthcare workers spread properly across facilities, and there are some new rumblings about this that I'll talk about now, that we discovered on Friday at the NHI consultation. And it also doesn't really take into account what we now know to be an uncompetitive and also alienated private sector. We're trying to bring these two sectors together, but we've spent quite a lot of time bashing each sector, and it's quite difficult now to make the changes that we need to make and to develop the trust that needs to be developed. And so what we're saying is that we need to grapple with why we have the problems that we have, and then firstly what the problems are, then why we have them, and thirdly what we're going to do to resolve those problems, and then to target resources and policy and legislation at fixing those problems. Now what the NHI bill does is it focuses on one problem, and that's financing. And that's a big problem, there's no question. We don't need to talk about how much of GDP goes to each of the public and the private sector. There's a massive maldistribution. But there's a problem in assuming that fixing the funding is going to fix the problem. And that's particularly the case when given what is said about the NHI fund in the bill. And that is that it's this superstructure. This thing is supposed to decide what to pay, it's supposed to make the payments, design health services, elect what services are necessary, decide which facilities to accredit, conduct research, including collating utilization data, monitor quality, monitor health outcomes, do health economic analysis, do pharmacoeconomic analysis. It's supposed to do all of this. And this is a fund that doesn't exist yet, with a governance structure that's centralized essentially in the ministry, because it's supposed to both account to the minister and, the bill says, assist the minister to perform his functions. So the NHI fund is essentially taking over a number of the functions of the National Department of Health, and changing the focus of the health system. And in order to do that, in order to make such a big shift, you need to be careful on governance. You need to make sure that you have the right people, but more importantly than the people, you need to make sure you have the right processes and the right systems. And we're worried that there's a bit of a gap there, that there aren't the kind of checks that would be required to ensure that this fund that is going to be handling all health money in the whole country is going to be able to do that. It's not clear how this fund will be immunized from the rot that's currently infecting provincial departments of health and state-owned enterprises and much else. And worryingly in the Act or in the bill, it doesn't deal with one of the biggest problems in health at the moment, which is governance and management. And I think it's politically easy to blame the minister for everything, and you know, occasionally these things pop up, that the minister's the problem, he must be fired. But often, the same people who are saying the minister's the problem, he must be fired, have not been pointing the finger at the MECs, who for a long time have been mixing politics and administration very conveniently in provincial departments of health. And so we really, really need to be dealing with these governance and management problems if we are to fundamentally change the way our health system works, which we need to do. So what within NHI then is the role of the private sector? As I say, there's not a whole lot of detail. Private providers are now going to be providers for everybody, because if you get accredited and if you get certified, you can be purchased from as a private provider. They should have the same structures as in the public health system. Those structures should be functional, so there should be a referral protocol, which is a good thing. Because as we've discussed, the private sector doesn't really have much of a referral protocol. It's very easy to go directly to specialists. There is a problem, and it'll be easier for private providers potentially to organize themselves and get the contracts that will be required from the NHI fund. So when you consider that there's so few public facilities that will at this stage be able to contract with the NHI fund, it might be quite easy for private providers to rally around and contract, and that could lead to a bigger privatization of health. That's a real risk that we've got to consider when looking at how we're developing this policy. The role of medical aids is extremely unclear. There's a few mentions of the idea that medical aids could be responsible for complementary cover. So anything above this basic basket of services would be for the medical aids to deal with. In earlier iterations of the policy, that complementary basket was described in, I think, I don't know the right word, maybe facetious or oversimplistic terms, as being things like nice glasses, like nice lens, frames, and designer frames and plastic surgery. But I suspect that the basic package of goods won't cover everything other than designer frames and plastic surgery. And so how much of a space is left for medical schemes is very unclear. And particularly how much of a space is left for them, or in addition, how much of a space is left for them in the transition towards NHI, also a question. So for the private sector, the HMI report provides, I think, a diagnosis, and a really detailed diagnosis. It provides some recommendations for how to resolve the problem in the private sector. At the same time as the NHI bill came out, the Medical Schemes Amendment Bill came out. And what that did was to almost start. So it made some recommendations, or it makes some provisions on how the medical schemes environment should change in order to support national health insurance. It doesn't go particularly far, and it doesn't do everything that was included in the press statement that it does, but it goes some of the way. So it doesn't ban brokers, as Sharon's. It does what the HMI panel is saying that it should do, which is to make brokers an opt-in function. It doesn't do away with co-payments. It says that there should be less money retained in reserves by medical schemes and their administrators. And so, it increases the powers of CMS, which doesn't really play the same role as brokers, but it does have an important role to play in regulating medical schemes. And so there are some positives in the Medical Schemes Amendment Act which move us in the right direction. But there's still quite a lot more that needs to happen. So what then do we need, in our view, to move forward and to ensure access to healthcare services, and to ensure a system that provides that access, real access, to everyone? And I think what we need is a proper path. At the moment, through the HMI process, we're on the way to having a path towards a private system that is functional and that can be sustainable. In the public system, we don't have that path. The NHI bill is not that path. The NHI bill provides an idea of what what a system could look like in the future. It gives a bit of information on a fund, and it doesn't really show us how we're going to get there. And that's a problem, because while a bill doesn't need to show every single step of the way, a bill isn't a clear plan, it needs to give us an indication of the way we're going to reach the outcomes that we want to reach. We need to know what the transition is. We need to know what the stages will be. And we need to ensure that in transitioning from where we are now to where we want to be, we're not entrenching some of the problems that we're seeing in either the private or the public sector. And there's risks of that in some of the rhetoric around, and even in some of the wording of the NHI bill. There's risks of entrenching some of the problems in the private sector when it comes to separation of groups of people for funding purposes. And I won't go too deeply into that. So I think to start off with on that path, we need to acknowledge the problems that we have, rather than trying to avoid them, even if it's politically difficult. And this is all very politically difficult, because it involves a lot of finger pointing and kind of behind your back finger pointing. In the public sector, there's some clear things that we need to do. We need urgent improvement of facilities. We've been talking about this for a long time. We've had ideal clinic programs, but we need something that is much broader and much deeper than ideal clinics, and that is much broader and deeper than the piloting program under NHI. There is maybe some hope from this new national quality improvement plan that was sprung on everybody who attended the stakeholder consultation on Friday, which talks to the improvement of health facilities in the interests of NHI. But we don't really know the details to that either. What we also need in the public sector is a real human resources strategy and plan. We've had a human resources strategy for some time. None of it was really implemented, and it wasn't really a plan. There wasn't really stages that you could see being implemented. We need to know how we're going to retain healthcare workers, and what healthcare workers we're talking about, including people like community health workers, clinical associates, etc. We've got a lot of half-baked strategies, but no real plan. The National Quality Improvement Plan that we saw last Friday says we will put an end to post-freezing, which is great. And interesting, because post-freezing isn't even acknowledged as being post-freezing. So for the first time, we're suddenly saying we're going to end it. But it doesn't show where the budget for employing people into those posts that have been frozen for some time is going to come from. And that's a real concern. We can't just design a fund and not a path. We can't say NHI and then not have any real idea of what NHI is and be trying to implement it already.